terminal illness. So keep up the good work. And I'll say personally too, I'll kind of echo what Greg said. This really re-energized my career after 15 years in emergency medicine. This is really fun for me to work with these patients. Although they can be difficult, they can be extremely gratifying. So if you have this, if you can see the slides, these are the topics that we're going to cover. In a nutshell, again, what we're doing is we are identifying and treating patients in the emergency department. We are inducting them with buprenorphine when they're appropriate and when they're willing. And we're doing it for up to 3 days because that's what the DEA says we can do. So we're going to talk about the rationale. Why are we doing this in the emergency department? My guess is that everyone that's listening understands or believes that MAT itself is effective. The question is, why do it in the emergency department? Got one slide on how we funded this. I have several slides with our process and our protocol, and we can get into the nitty-gritty as much or as little as you'd like. And then we'll end with a few slides that look at our data from Summa Barberton. So I started a program for medication-assisted treatment or therapy in the emergency department. It's pretty obvious. This is where patients come. They come for a wide variety of reasons. They come after they have been rescued with naloxone from an overdose by the first responders. They come with multiple medical or psychiatric complications of their substance use. So we see skin abscesses all the time. We see endocarditis and complications of endocarditis. We see acute hepatitis. I saw a patient just yesterday with liver failure from hepatitis C. We see
also
spinal
seen
cord.
Probably a 10-fold increase in epidural abscesses as well over the last several years.
Jeez. Yeah, I had never seen a case at Alliance Community Hospital. I've seen 3 in the past 6 months at Summa. So it is an epidemic. It's a devastating disease. I saw one of those 3 days ago. All the psychiatric comorbidities, anxiety, depression, suicidal ideation, psychosis. To my ER colleagues that are listening, I've seen some patients and identified patients that are frequent flyers with recurrent GI symptoms, cyclic vomiting and diarrhea. There's a case down in Alliance I remember. Patient came 5 times in 4 days, was admitted, was scoped. I was the 5th doc to see him, and I finally said, you know, are you dependent on opiates? And after I pushed him a few times, he acknowledged he was dependent on Dilaudid. That's why he was in the ER with recurrent GI symptoms. We also see patients in acute withdrawal. And sometimes they'll tell us that. Sometimes they will manufacture a complaint in a hope to get a shot or a script for narcotics. And possibly more so than any other patient, the ED is really the critical access point for healthcare for these patients with substance use disorder. We're that for many patients with many chronic illnesses, but for these patients, probably more than any other. And frankly, there's no barriers to coming, right? Transportation is even available. They can dial 911 and they will be brought to us. And we're 24/7 available with no financial barriers. So that's why patients come, and that's why the ED is really the ideal place to identify these patients and start them in treatment. The second reason that we want to start MAT in the emergency department is because it is effective. There was a landmark study done. It was published about 4 years ago by Dr. Gail Donofrio out of Yale, and she and her colleagues randomized people to 3 different treatment protocols in the emergency department. The treatment protocols, so look at that center column first, the referral group. That's also quote unquote usual care. And for most of my career, this is what I did. Here's a phone number, good luck. So 1/3 of the patients got that, usual care. 1/3 of the patients had that referral and a brief intervention. It's about a 10 to 15 minute brief negotiated interview, and then a warm handoff to a clinic, so a facilitated follow-up. The 3rd group had both of those things, plus they were dosed with buprenorphine. The main outcome that Dr. Donofrio looked at was who remained in treatment at 30 days, and the numbers there are obvious. Twice as many patients that were initiated with buprenorphine, that were inducted with buprenorphine in the emergency department, Twice as many were still in treatment at 30 days. And then the opioid use days per week, that's a self-report, but you can see it was about 2 to 2.5 times higher in those patients who did not receive buprenorphine. She followed them up. The remaining in treatment persisted at 2 months. The initial data actually showed it did not persist at 12 months, but there's been lots of studies since then. So that's why we did it. How do we fund it?
I'm going to interject something here before we actually talk about the grants. I mean, we're going to make this sound like it was easy, but it obviously is not. You have to, first of all, before you can even apply for grants, you've got to have hospital or health system support in this. And I think most of your health systems will realize, especially nowadays, that this is a critical issue for the community. But Summa Health in particular was very supportive of us moving forward. You have to have a champion for this, not just in the emergency department, but you have to have a champion within the hospital. And Dr. Kolb mentioned Jamie McKinnon, who is the vice president at St. Thomas and Summa for behavioral health, was instrumental in really being the linchpin in not only helping us set up the program, but getting us funding. And so you really are going to need somebody within the system that can help get funding for this, because we'll talk about this at the end, but we've gotten a lot of grants for this, and certainly opiate use disorder is a topic of extreme interest and funding right now. Whether that will be true in 3 to 5 years, we'll have to see, but we have to make it self-sustaining at some point. We did work with the emergency department physicians to get them X waivers, and only right now about a third of our providers have gotten their X waiver. That allows you to write a prescription. All emergency physicians, any physician can write for it in the emergency department. So all of our clinicians can write or give it in the emergency department, but only those with X waivers can actually give a prescription, and that can be helpful for bridging over the weekend. And then we've had to develop a community interaction, community connection to get them help. Dr. Lewis is one of those providers. We've had a great deal of support from the Department of Psychiatry. Brightview has also been helping with some of our follow-up. Our family medicine clinics, both at Barberton and City, are involved in that. But there is a whole process and a whole system that you have to have set up and have the support and drive to do this, because then you can go out and get the grants. And again, we're happy to talk with any of you, particularly our emergency department providers, on how to go about doing that. But it really does take a village to get this done, and takes a lot of coordination to do this.
Right. And I think and hope there'll be additional money. There was a lawsuit settled, I think, last month for $200 million, Cuyahoga and Summit County. So on the slide there, you can see we access 3 main sources of funding: the Ohio Department of Mental Health, the United Way of Summit County, and that last one there trickled down from the Center for Disease Control through the Ohio Department of Mental Health. And we kind of had a joint grant with Brightview Health, which is an addiction recovery organization throughout Ohio. So that's how we funded. And we'll talk about where that money went, or where it goes. So I have a slide with a narrative on the process, and then I have our actual day 1, day 2, and day 3 guidelines that is posted at every workstation at Barberton and Akron City on the next slide. But once a patient is identified, we try to move him or her to a dedicated area of the emergency department. At Akron City, it's a hallway, probably about 100 feet away from the main emergency department, where it's much quieter, much nicer, and that's dedicated just for those patients. At Barberton, it's just one of the sections that otherwise is not used. And again, patients self-identify, especially at Barberton. They come to the triage window and say, "I'm here for MAT treatment," because the word is getting out now. after 18 months. Other times the providers identify them based on their medical or psychiatric complaint. Once they're identified, they meet with our nurse addiction care coordinator. And I would say if there's any single key to the program, there's not, but if there is any single key, it has to be the nurse addiction care coordinator. This is a nurse, it's currently all women at both sites, who has done some additional training in addiction recovery care, may have a background already having worked in a facility, and we have them 12 hours a day. And their only job is they meet with patients that have any substance use disorder, not just opiate use disorder. And they'll do a brief negotiated interview. They will offer to engage a recovery coach, which I would say that is another key. The recovery coaches have been wonderful. These are recovering addicts themselves who have had training and a long track record of sobriety, who are kind of a peer to these patients that another provider may not be. They help with things like getting patients rides and transportation, and they can speak truth and tough love and all those types of things with the patients. We provide various resources. One of the resources is Narcan to Go is offered to every opiate use patient. And then the nurse addiction care coordinator also works hard to schedule follow-up with all of our community providers. Some are within SUMA, some are outside of SUMA.
We also received a grant from a private donor to put a resource bag together that lists a lot of the resources and some other resources that the patient might need, and we give them that bag. And this scheduling follow-up is really, I mean, that's critical. And so we've worked very hard with the community resources, Department of Psychiatry, Family Medicine as mentioned, Brightview. There is actually a website too, www.findlocaltreatment.com, that can help get a scheduled appointment. But that is as Dr. Lewis alluded to, we're in some ways, I know she was frustrated, but we have probably more resources than a lot of other areas, and we're still stretched a little bit thin on that. So that's a very big area that you really, have to try to develop before you start this program, because just getting them in and getting them induced isn't going to be sufficient. They need that follow-up.
Great. This narrative is getting into our protocol, which is the next slide, but I did want to mention, I think Dr. Seberg mentioned it, any provider with a DEA number can order buprenorphine from the hospital pharmacy. You do not need your X waiver. The DEA will allow that for up to 72 hours. So that's why we have a 3-day protocol. And the vast majority of times we can get a patient followed up in a long-term ongoing clinic within those 3 days. If not, that's why we have many of our providers X-waivered, and we're pushing the rest of them to get it done. So if needed, they may return for day 2 or day 3. So the lion's share of the work is done by the addiction care coordinator. This is what our protocol looks like. Simplified it. We try to be ruthlessly simple, but this took a tremendous amount of work and refining and working with our PharmDs. I won't spend a ton of time on this. Just hit the highlights. Every patient signs in as an emergency medicine patient like normal. Everyone gets a medical screening exam. Everyone's seen by a provider, physician, PA, or NP. Day 1 only, there's required testing on our guidelines, a CMP, an alcohol level, a urine drug screen, and for our female patients, a pregnancy test. I wrote on there for—
Hey, Jason.
Yeah.
Hey, this is Greg. Really quick, but for everybody on the call, but with ED, the one thing that even myself I had to overcome is this is very, very safe, and making sure that we had a safe protocol. Most physicians and emergency physicians are creatures of habit, and the other day we had a meeting. Jason said something that really resonated with me, which was when in residency we were all taught that nobody dies from opioid withdrawal, not like people can die from alcohol withdrawal. And Jason said, yes, that's correct, but they die from overdose. And so they feel so miserable that their only way to get better is they go use again, and then it has carfentanil in it and they're dead. And so I think the key for me when we started this a year ago or so, and for those who haven't used it, is extremely safe. And that's the one thing I think to overcome people's fears who, quite frankly, aren't necessarily specialists in this. So that really made a lot of sense the way Jason worded that, because we're taught that, you know, people feel miserable, but they don't die from opioid withdrawals. Yeah, well, they die when they go home and use and overdose. So,
right. And we've talked about with our providers too, Greg, that the main danger, quote unquote, is that we'll precipitate withdrawal. And I did that myself a few months ago. So we're all still learning, but the guidelines are to help prevent that. I wrote on there for all the providers to be cautious if they're benzo or methadone positive on their urine drug screen. We talked this morning that benzos are not a contraindication, or certainly not an absolute contraindication. You need to look at their clinical status. If they're awake and alert, a benzo positive drug screen is cause for counseling, not withholding buprenorphine. Methadone's a little trickier because you can precipitate withdrawal because it has such a long half-life. And then we do use the clinical opiate withdrawal scale or score. The nurse addiction care coordinator does that. I often will do it on my own. Some of the providers do, some of them don't. It's one tool to help assess their level of withdrawal. But most of the people on the call probably know that if you dose them with buprenorphine and they're not in probably moderate to severe withdrawal, you can precipitate withdrawal, which is very uncomfortable. Then they've had a bad experience with buprenorphine, and you may lose that patient. So the COW score and the clinical assessment and the patient's self-report of when they last used and how sick they're feeling, we're training all of our providers to use those things to dose them. We're relatively conservative on day one. I think it's the FDA label indication says the max dose on day one is 8 milligrams. For the ER colleagues on the call, if you, for instance, look at California ACEP's guidelines, they go way higher than that on day one, up to 32 milligrams. But locally, we've been more conservative. Most patients get significant relief of their withdrawal symptoms with 8 milligrams, maybe not complete relief. We offer them Narcan to go. We can offer them a Hep A vaccine, and the addiction care coordinator is working on their follow-up. And if it's not available the next day, we just invite them to come back. By the way, our addiction care coordinators are present from 11 a.m. to 11 p.m., 7 days a week at Barberton and City. That's also for the community. These patients can come anytime. Most of the providers know how to dose it, but it's better when they can come 11 a to 11 p to get that dedicated time with the addiction nurse.
Yeah, I found that, you know, I give out, obviously we give out the Narcan to go. Another drug that I often give because requested is Zofran for them. So I've given that as well.
Yeah. Day two, we don't really require any testing. It's patient specific. And all that detail about the cows and dosing, you know, again, those are just details. You can read over those. 16 milligrams on day two or day three if needed. This slide has a lot of data. I'm moving into our final few slides on data from Barberton. So there's a lot of stuff here. Don't get lost in it. I'll walk us through it. Left to right is time. So we first started recording data third quarter of last year. And this slide only goes up to quarter two of 2019. The very top green line is number of patients in the emergency department identified with substance use disorder. The kind of mauve or dark pink bar is how many evaluations the addiction care nurse performed. The lower, thinner green line is how many patients were identified with opiate use disorder. So to clarify, if we have a patient who's dependent on or abusing methamphetamine, we will absolutely ask the addiction care coordinator nurse to see him or her, engage the recovery coach, talk about resources, things of this nature. But the lower, thinner green line is the opiate use disorder patients that were identified. And then kind of the brown bar are those that were inducted in the emergency department with buprenorphine. Wow. So I was thinking about this, Greg. I mean, I think it's on the next slide. We've had 500 people that we've inducted since we started. Like, that makes a difference.
Yeah. Wow.
If I could just go say one other thing, if you go back to that last slide, you can see we started out sort of slow and then it's built up. And, you know, Suma was good about, they put some print ads, they did a couple of radio ads. It wasn't a big media blitz. This is a word of mouth within that community that hears about this. And so we have now people coming down from Cleveland because they've heard about it.
Wow.
And so it is something that's building up. We're seeing the same thing at City. Once it gets out more into the community, our volumes will start going up at City as well. But this is pretty typical as you start an MAT program.
Wow.
Yeah, I think one thing to add too is, I mean, I don't have this percentage, but it's very, very, very high. These patients are nice to you. They're extremely grateful. This is not like for the other colleagues, the overdose that, you know, gets mad at you that you gave them Narcan and cusses at you and storms out of the ED. These people truly are appreciative that they're getting help. And that's the thing I think a lot of us realize, that they're not, you know, yes, they may have made a bad decision or they had a terrible orthopedic injury and they became addicted. Most of these patients want to be good citizens and they need the help. And that's what I've come to realize. These are not bad people.
Yeah, they're sick people with a terminal illness. And like all patients and all of us have responsibility for their choices. Anecdotally, I was at City yesterday. I asked our addiction care nurse how many patients she's seeing a day. The data you're looking at is from Barberton. We launched at City 2 months ago. She's seeing 8 to 10 a day. Half of them are opiate use. The other half are other substances. So it's starting to ramp up in Akron.
Wow.
Just a few more slides. This is the breakdown of payment source. Probably not surprising. 2/3 Medicaid, 10% commercial, 15% self-pay, and a smattering of others. This is a kind of a busy slide as well. Don't get overwhelmed with the numbers. I would say look at this pie chart. We inducted 51% of those that were evaluated. So 41% were not clinically appropriate. They may not have had opiate use disorder. They may have had methamphetamine dependence, alcohol dependence, etc. Only 8% that were appropriate declined. So most patients that qualify for opiate use disorder and are in moderate to severe withdrawal accept the induction. This is our follow-up data from Barberton. This is first appointment, 3/4 show for their first appointment. And we've worked really hard to lower any barriers, including providing transportation. It's that warm handoff that's critical. So patients are told you're going to see Dr. Casper on Friday at 1 o'clock, and the recovery coach is going to pick you up. So yeah, everyone has worked so hard to do that. And by the way, this is obviously where the grant money's going. 12 hours of nursing coverage a day is expensive. Okay. So that's all the data I have, and I wanted to leave some time for questions or conversation.
Wow, thank you all so much. That was